Hello, this is Dr. Devin Price, and I'm here today to talk a little bit about an introduction to neurodivergence and neurodiversity issues for providers. So, mental health providers, medical care providers, educators, school psychologists, typically people who work in institutions who are wanting to know more about how they can better support neurodivergent individuals and better neurodiversify their practice. This is a evolution of a talk that I've given at Planned Parenthood, at a bunch of different mental health clinics, at a bunch of different educational institutions, and have pulled together a lot of information from just interviewing tons of neurodivergent individuals about the ways in which providers have failed them and the ways in which institutions are inaccessible to them, as well as the research on how this impacts people's outcomes. So we're going to dive right on into it here. I'm just going to pull up my slides and start talking about the topic today. Here's just your general agenda. We're first just going to do a quick introduction to what neurodivergence is and why it's an important frame for considering some of these struggles. And we'll take a really expansive look at that as much as time will allow. We'll talk about masking and how masking is created from external social pressure and exclusion and oppression, and how it creates a lot of issues in the clinic room, in the classroom, and so on. We'll go through a lot of the different ways in which ableism, a lack of accommodation for neurodiversity, and masking pressures make provider interactions less effective and can really fail a lot of neurodivergent individuals, what some essential accommodations are if you're trying to address this stuff, and then close out on emphasizing why this project of embracing neurodivergence and unmasking neurodiversity is really for everyone. So, first, I wanted to just do a quick rundown of some of the really common problems that happen for neurodivergent people when they enter a clinician's office, when they go to therapy, when they are talking to a school disability office official, all of these different kinds of institutional interactions. And here are some of the really common problems and unmet needs that I hear over and over again. One really common problem is constant misgendering, comments on appearance, and odd looks at the person for seeming to not belong. So, a really large proportion of neurodivergent individuals are trans or gender nonconforming, or nonconforming to societal rules in a whole bunch of different ways for reasons that we'll get into. We tend to look different to other people and be othered for that, and that really strikes us from the moment that we walk through the door, with people hesitating before they interact with us, not knowing how to treat us, using the wrong language for us potentially, and being uncomfortable with who we are. There's the physical inaccessibility of the space, really bright lights, loud televisions in the waiting room, blaring sounds, lots of conversation, echoey rooms with poor acoustics, and just generally a lot of movement and busyness and stimulation that can be really stressful and hard to process. And what people who aren't autistic or an ADHD or have an anxiety disorder may not realize is that this kind of overstimulation can really send you into fight or flight mode. It's no small thing. It's not a mild annoyance. It makes it very difficult to process, and it registers as akin to physical pain for many of us. Another big problem in a lot of provider settings is not enough warning before changes. You're being taken from room to room, a bunch of tests are being given to you, you're being asked a bunch of questions over and over again, sometimes repetitive questions, and not being told why certain questions are being asked or what they're going to determine. Maybe a bunch of terminology is being thrown at you that you can't understand, and it means that you can't follow what's happening. You can't necessarily give the information that your doctor or your therapist is trying to get out of you because you can't understand why they're asking the question. And you're also not being given enough time to think about what your answer is. That's another big principle that we'll come back to later on in this presentation. How much time neurodivergent people need to check in with their bodies and minds, translate the question that's been presented to them, think up an answer that is true for them, and figure out how to translate that back into neuroconforming speech or presentation. That takes a lot of time, and in your typical doctor's office visit or meeting at office hours with a professor or something, you don't have enough time to actually break things down in that way. A lack of clarity on expectations is another big problem. Patients, students, etc., not being told what to expect. What is going to happen during this meeting? What is the purpose of this appointment? What information is being collected about me and why? What is going to happen afterward? What are my next steps? A lot of times it's just a stressful, overwhelming blur, and usually somebody really impatient dealing with you the whole time. There's also the inaccessibility of any kind of web interfaces or phone systems that are used to interact with the provider, whether that is a really poorly organized web interface for scheduling an appointment or a reliance upon phone calls. When we're talking about a population of people that may find phones really difficult or may find written information difficult, there's a whole bunch of different needs that people with different disabilities are bringing to bear here. And when you only have one method of asking a question, finding your records, scheduling a meeting, and it's not one that's accessible to a bunch of different processing styles, you're going to have a lot of issues, and you are basically locking a lot of people out. Other issues are a really strong emphasis on face-to-face and real-time interactions. A lot of providers feel like there's something special about meeting in person, that when I can look someone in the face, I can pick up on what they're feeling. There's so much that I'm getting from their nonverbals, and it's much more effective to me than getting an email or a message from them. Whereas for a lot of neurodivergent people, that's really not true. Our facial expressions and nonverbals are being misread by other people. We are having to filter ourselves when we're around others and censor our behavior so we don't seem weird or distracting or immature or crazy. Any number of other judgments that might get thrown at us. So a face-to-face interaction for us can be a massively stressful and really false encounter. So a lot of times you get more accurate information from a message that's been typed up or notes that we bring with us, rather than that face-to-face intuitive kind of processing. There's a big problem of lack of belief when we are confused, need support, or in pain. I'll get into that more later. There's a failure of providers to really empathize with what neurodivergent patients or students are going through, or to understand that our emotions can look very different. And often there is just cultural assumptions of here's what it means to work, here's what it means to collaborate, here's what a person looks like when they're paying attention. That really does not work if you are someone who can't make eye contact, who's fidgeting in their seat, who talks to themselves, or who just otherwise presents in a neurodivergent way. So what is neurodivergence? It's something that gets thrown around a lot these days. It's often used simply as a euphemism for autism or ADHD. And certainly most of my work is about autism, so that is the tradition that I'm kind of speaking from. But neurodivergence is a much wider umbrella than that, and all of these principles apply in a lot of diverse ways to a really diverse group of people. So any person who deviates in some way from the neuroconforming standard is a person who we can say is neurodivergent. So the neuroconforming standard, to neuroconform, means to meet your particular time and place and culture's rules for what it means to be an appropriate, mentally healthy individual. So that might mean things like making eye contact, dressing up in a suit and a tie when you go to a job, keeping your fingers out of your mouth, not chewing on your fingers or picking on your nose or messing with your hair when you're talking to someone. Keeping your emotions relatively repressed, not screaming or having visible meltdowns, not crying at the quote-unquote inappropriate times, not being too enthusiastic about the wrong things, not talking too much, really just projecting a kind of general pleasantness, but no real extremity in emotion, and being very filtered and controlled. Generally, the neuroconforming standard is the standard for a person that can go to school and go to work without any major social issues or productivity issues. That's what it means in our society today to be a mentally healthy, quote unquote, conforming person. And anyone who deviates from that in any way is at risk of being seen as lesser as a person and dealing with really negative outcomes as a result, be that homelessness, being fired from a job, being bullied by peers, and a panoply of other outcomes. So, neurodivergence encompasses not just autism, ADHD, dyslexia, some of the learning disabilities and developmental disabilities that often come to mind for people, but every stigmatized difference in how people feel, think, or behave. So, people with mood disorders like bipolar or depression, people with anxiety, people with social anxiety, people with sleep disorders, people with OCD, people with eating disorders, people with Tourette's tics, any visible difference that impacts a person's relationships and how they relate to others. Personality disorders are encompassed under neurodivergence. The groups that you've been told the most in society to hate or to see as defective, people with supposedly antisocial personality disorder or narcissistic personality disorder, those are people too who are stigmatized for how they think, feel, and behave and excluded because of it. And so they are included under that umbrella. Neurodivergence also includes addictions, Tourette's, as I mentioned, intellectual disabilities, brain injuries, and also what I would call political disorders. So, what have been considered mental disorders in the past because a person was so challenging to their society and their status quo within society that they were seen as sick. So, that includes women who were diagnosed with hysteria, queer people, because of course homosexuality used to be in the manual of mental disorders. Black activists during the civil rights era who were seen by their therapists and by the prison industrial complex as paranoid for saying that the world was turned against them, even though the world very much was. Communists who were lobotomized. Many groups of people have been assigned a mental health label because they didn't conform with a profoundly unjust society. And so we can see that a mental health label is an inherently social formulation. It's a social judgment that reflects this person doesn't fit in to their time and place for some reason. They are not following the rules. They are not neuroconforming enough. And that is what makes them sick or defective in some way. And a lot of times treatment means forcing them to become less of a problem to the existing status quo, to the state, to the police, to schools, to hospitals, and so on. So when we look at it from this lens, neurodivergence is an innately political identity. It's not just a personal identity, and it's not just a mental health label or a diagnosis. It exists beyond those bounds. It's an identity that came from a political movement, the movement against groups like Autism Speaks, or against applied behavioral analysis therapy, which was existed and was created to teach and force neurodivergent people to neuroconform. There has been a large movement of disability justice dating back to at least the Americans with Disabilities Act protests that really declare that disability is a state of difference. It's a state of diversity that has been excluded and not accommodated for. And that all of the problems, or the majority of the problems that disabled people or neurodivergent people experience in the world comes from them being treated as lesser or other or undesirable and excluded from public spaces because of that, or forced to conform using really harsh corrective therapies, social punishment, the threat of exclusion and ostracism, and so on and so forth. So when we look at it from this lens, we can really ask, who isn't neurodivergent? Almost every person has some experience of feeling different or lesser in some way, or being told that the way that they think, feel, and behave is wrong. Whether that's having to grin and bear it through a depressive episode and dragging yourself into work, even when your heart is just telling you that you don't have it in you. Or if it's a far more severe case of exclusion, something like being someone who cannot talk in a world where everyone assumes that your humanity is defined by your ability to speak. And so nobody listens to you, people touch your body without asking your permission, they talk about you as if you're not there when you're in the room, and all of those kinds of forms of oppression that a lot of nonverbal autistic people or people with intellectual disabilities experience quite a lot. I alluded to ABA therapy, but I did want to just take a moment to touch on it here. Applied behavioral analysis therapy is still the only quote-unquote evidence-based therapy, quote-unquote, for autism that is still approved by most insurance providers in the US. And it was created by someone who also created anti-gay conversion therapies, a man named Ivar Ole Lovas. And with both of those therapeutic techniques, what Ivar Lovas believed he was doing was training people who stood out to better conform. So under ABA therapy, if a child talks too much about their special interests that they're super passionate about, they can get electroshocked as punishment or have hot sauce put on their tongue. Children under ABA therapy are forced to sit in a chair, calmly not moving their bodies, and reciting a polite conversational script, and they're not allowed to use the bathroom or get up or ask for any help if they don't neuroconform in that exact way. ABA therapists are trained to withdraw all attention and support from a child if they act up or they have a meltdown or if they do anything kind of disturbing or annoying, anything that basically marks them as different in some visible way that presents a hassle to others. And they are conditioned with a series of rewards and punishments to become a person who is more in alignment with the societal standard. And ABA therapy has been found to be very traumatic for autistic people who undergo it. It often conditions us to be more susceptible to abuse because we're taught to no longer speak up or be different or assert ourselves in any way, and to transform ourselves into being as agreeable and quiet and small of a person as possible. But this is really just a really extreme example of what the project of neuroconformity does to every neurodivergent individual. You're told to stop being so loud, to stop moving around so much, to stop complaining about things that don't bother other people, be that the tag in the back of your shirt or a person touching you without your consent, and that being considered normal. The social project of neuroconformity makes everyone smaller and more compliant, and says that if there is a difficulty moving through the world, that's on you. That's your fault for not grinning and bearing it. It's not the physical space for being built in a way that's hostile to you. A lot of what ABA therapy really trains autistic kids to do is to take part in something called masking. And masking is something that transcends people who were diagnosed as autistic. It transcends autism in particular, and really is an experience that we see among all neurodivergent individuals, and it's created by those neuroconformity pressures. So in the scientific literature, we see that masking is comprised of two big kind of buckets of sets of traits or sets of behaviors. One set of behaviors is camouflaging your disabled traits. So forcing myself to make eye contact, pretending to know only a normal amount about a subject that I've studied obsessively for years, blending in by mirroring other people. These are all camouflaging of disabled traits. Compensation is another big component of masking, and compensation means making up for the lack of accessibility in your environment in some way, hiding the needs that you have. So that can look like, for example, taking on only a part time work from home job because you cannot handle the constant socializing of being in a work environment 40 or more hours per week. And presenting that as if that's your choice when really it's the only option that you have. Or another way that a lot of neurodivergent people compensate is that they pour all of their energy into work and they spend the rest of their lives resting and trying to recover from the stress of work. So they don't have hobbies, they don't have relationships or friends, they don't get to do anything personally enriching, they don't have time for exercising or looking after their physical needs. Literally, all they're doing is just living life by the skin of their teeth, trying to pour all of their energy into getting enough work done to pay the bills or getting through school. Those are just some examples, but there is a long, long list of strategies that individuals employ to hide the fact that they are disabled and to make themselves more neuroconforming. So that can mean things like faking smiles and laughter, forcing yourself to make quote unquote appropriate facial expressions, forcing yourself to make eye contact, memorizing scripts of normal interactions so that you know what to say when you go to the grocery store or you're on a job interview or you have a meeting with a doctor or teacher. Often learning behavioral patterns and mannerisms from just mimicking people or watching them and imitating them on TV. Pretending to understand what's going on when a situation has not been explained to you or expectations have not been. Being really, really agreeable or really, really inhibited and shy and withdrawn. And both of those strategies are to ensure that you're never seen as too much. Because a lot of us run the risk of being seen as rude, annoying, loud, chaotic, and so on. And so we try to compensate for that by hiding away as much as possible. Also, to cope with things like the stress of all of this and the intense bombardment of sensory overwhelm that a lot of us deal with, many neurodivergent people use drinking, drug use, self-harm, or eating disorders to manage our physical stress. So we might not eat in order to tire ourselves out so we're not as stressed. Or we may use alcohol to relax ourselves a little bit so we can seem a little bit more socially easygoing. So we see that neurodivergent individuals, particularly ones who mask, are at a much heightened risk of self-harm, substance abuse, eating disorders, and related issues, including all the way up to suicidality. Masking is a major predictor of suicide risk. Because when you think about it, if you are never honest about who you are and how you feel, ever, then you are not going to get the support you need, you're not going to have genuine relationships, and you're never really living as yourself. So it's a very distressing and depressing state of being in the world, and it can be a very hopeless feeling one. So having kind of set the table here a little bit and explained what neurodivergence is really about and what the struggle of being disabled in this world really can look like, let's talk more specifically about how masking and exclusion make it really hard to have a worthwhile, helpful interaction with a therapist, a doctor, a teacher, a school psychologist, or anyone else at these kinds of powerful institutions. First, we know that non-disabled people or neuroconforming people are very bad at reading the emotions of neurodivergent people. So the study that I have here comes from Autism Research, the journal Autism Research, so it is specific to autistics, but we find that very similar dynamics play out whether you're looking at someone who is an ADHDer, has bipolar disorder, has borderline personality disorder, and any number of other disabilities. A lot of times, neurodivergent people, we are the ones that are stereotyped as lacking empathy, that we can't read other people's facial expressions and tell what they're feeling or feel their pain. But when we really delve into the data, it seems to be the opposite. A lot of autistic people, we work really hard to memorize what other people's facial expressions look like and what they might mean. We practice understanding others' emotions and empathizing with them really, really hard because we are sometimes mystified by it. And non-autistic people, the data shows, don't try to meet us halfway. They mostly take their initial gut reaction to how we present at face value. So, for example, a lot of autistic people, when we're focusing, we scowl, or whether it's just a task we're completing or we're trying to understand something, we'll furrow our brows, we might kind of grit our teeth. I'm exaggerating what my face naturally does here, but you've probably already seen it in the course of this presentation. When I'm focusing on something, I make this kind of, I guess, grumpy looking expression. This is also an expression that you see neurotypical people make when they're doing something really hard for them. So if you look at videos of Jimi Hendrix doing a really intensive riff on a guitar, he's making that face. If you look at a really expert piano player doing a really complex piece on the piano, they're making that kind of face. It's a face that people tend to make when they're doing something really challenging. And for autistic people and a lot of neurodivergent folks, focusing and enduring lots of overload and just being in the world is really challenging. So we look really focused, and that gets taken as grumpiness, that we're mean, that we're judging other people, that we're impatient, that we hate being wherever we are, and so people dislike us for it. Another big issue with many providers is that they think we are cold. Many of us come across as robotic or flat to them. This is something, again, you might pick up on in my voice. My voice tends to sound sarcastic to people or flat, and I've actually put years of effort into putting more emotion into my voice. That is masking. That is me imitating neurotypical people when I try to put emotion into my voice. Really, I would like to be able to just say what I'm feeling and have people believe it. I'd like to be able to just say, I'm happy, and people believe that I'm happy without me having to do a big fake performance of happiness. Unfortunately, most non-autistics just instinctively look at autistics and say, you're robotic, I can't connect with you, I don't feel anything from you right now, and also dislike you for it, which comes into the next problem here. Reflexive dislike and mistrust of neurodivergent individuals. So we find that within milliseconds of meeting a neurodivergent person, people who are not neurodivergent dislike them. Autistics are liked less than their non-autistic peers within seconds. Similar findings are true of other neurodivergent groups, and this really affects provider interactions. If you are non-disabled and you're interacting with a neurodivergent person in your office, and you get the impression from them that they're cold or unpleasant, or that they're being too fake and overblown in their emotions, you might dislike them, and that means you might spend less time listening to them, and you might not believe them when they try to tell you something that they have questions about or something difficult that they're going through. So these snap judgments really translate to teachers spending less time with a student if they're struggling, providers asking fewer questions or explaining things less to patients because they dislike them, and many of the needs and feelings of members of these groups being taken less seriously and them getting less support as a result. Another big issue that comes up related to this is that the pain levels of neurodivergent people are underestimated. So most of us exist in a state of sensory pain and confusion almost all the time. The world is not comfortable to us. Wearing clothing is not comfortable to us. Everything's too bright and loud. So we're really used to pain, and we're used to people not caring that we're in pain. So when we present to a doctor or therapist's office, we may seem totally fine. We might look like a number 3 or a 4 on the pain scale, flat affect, neutral, not screaming in pain. And we might be in agony, but our experience has been that anytime we're in agony, people tell us that we're overreacting, or that we are hearing something that nobody else hears, or seeing something that nobody else sees. And so when we go to seek care, we are still often underestimated in that same way. We're not presenting pain in a way that a provider can empathize with. And also, a lot of the time, we are so focused on making sure that we're understood, trying really hard to translate our experience into words, that providers will see us being so focused and not see any emotional expression from us and think, well, it can't really be that bad. Otherwise, you wouldn't be so calmly and so thoroughly explaining things. And so then we'll get less care as a result. Many neurodivergent people are seen as untrustworthy or manipulative in a bunch of different ways. And this also reflects society's attitudes towards disabled people in general. So if you're avoiding eye contact, people think you're lying. If you have really large emotions, people think that you're being fake or that you're trying to charm people or win them over. And so you are seen as manipulative. So that can happen to a lot of people who get labeled as borderline or to ADHDers. If you can't complete a task that everybody else thinks is easy and you keep asking for help, then your teacher might think that you are lazy or manipulative, that you're lying, that you're trying to get away with something. And so we see that for a lot of ADHDers who get labeled as lazy and don't get disability accommodations because of it. So this is a big problem that manifests in a lot of different interactions, whether you are seeking sympathy from your therapist or you're trying to get extra test time on an exam. If the way that you behave looks strange to people, people don't like you and they don't believe you. And those are biases that we see a lot of providers enact. A lot of providers think they are really good at sussing out who's lying to them. They think they have really good clinical intuition. And what that intuition often is bias, stereotyping and bias. You might think that you've come to recognize a pattern, but you are also reflecting biases about what you think trustworthiness looks like. Another big problem in provider interactions is difficulty communicating about feelings and internal states. So many neurodivergent people don't check in with our bodies often. We've been told a lot of the times that how we feel in our bodies is wrong and annoying anyway, that if we're uncomfortable, we must be lying. And so over time, we stop listening. So we may not know when we're hungry. We may feel pain but not be able to locate where it is in our body. Or in a therapeutic setting, we might be able to tell you that something is wrong, but we might not be able to put it in emotion words. So this headline here is from a piece that I wrote a few years ago called "Thoughts Are Not Feelings is Shitty Psychological Advice." And it's speaking to a problem that many therapists have, where they will challenge a patient to explain things that they're going through in emotion words. So I'm sad, I'm bereft, I'm in grief, I'm frustrated. And what we find is that for many neurodivergent people, those feeling words just don't quite nail what we're experiencing. Instead of saying I'm anxious, I'm more likely to say I'm worrying about this, 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 and this. I'm thinking about this. I'm going to share the content of the anxiety with you rather than say I feel anxious. Or if I'm sad, I might say I'm thinking about how everyone in my life is all going to die and I'm going to lose everything good that ever happens to me. Again, you're getting the contents of the thoughts, not the emotion word. Or we might use some kind of analogy or some kind of behavioral example to display how we're feeling. And there's just a mismatch there between what the provider is trying to find out and how we communicate. And a lot of times we are invalidated for the ways that we communicate. Another big one, perhaps the biggest one, that really taints provider interactions is the provider not considering neurodivergence and accessibility to disabled people at all. So the neurodivergent people who are most likely to mask are the people who are those who don't meet the stereotype of what a disability looks like. So with autism, the stereotype is white men who were obsessed with trains and present in a certain way. So if you have a young black woman in your clinical practice who can make eye contact, who is really emotionally expressive, and who can describe her thoughts and feelings in a ton of detail, but you feel kind of removed from her and like you're not really truly connecting with her, autism might never come to your mind because it doesn't match your stereotype of what autism looks like. If a man presents with complaints of anxiety and you have the stereotype that anxiety is mostly exhibited by women, then you might not get him the help that he needs. If the only experience you're having is just that you dislike a patient or that they're kind of boring and distant to you, you might not really probe deeper and think about what's going on with them and what's going on with you that might be getting in the way of you connecting. And so then you might not ask the right questions to find out that they are actually suicidal or that they are dealing with untreated ADHD or any other number of struggles. This also translates to the physical environment. The average clinical setting or school or other institution is super bright, loud, busy, overwhelming, and it is physically not built for neurodivergent people. And so you have a group of people that's already poorly understood and traumatized under a ton of physical stress and then being dragged from room to room and barraged with a bunch of questions and shown very little patience, and they almost never actually get the opportunity to speak up about what's on their minds or what they need. So if this is a problem that we want to take seriously and address, what can providers do to change things for the better? There's a lot of specific accommodations you can make, but first I want to talk about just the key principles that all of our work should be flowing from. And those are the principles of trust, patience, clarity, and autonomy. So trust. This is a spirit that you should really try to bring to your every interaction with clients under your care or students. Believe a person when they say they are uncomfortable or confused. I can't tell you how many times a neurodivergent person is not believed when they ask for help. Believe someone when they say they are in pain or say they cannot do something, even if they look fine to you or you think they should be able to do their laundry, study for an exam, read out loud in front of the class, whatever it is. Also, trust that behavior is communication and that you are getting messages about a person's comfort level all the time. So if they're wincing in pain or grimacing, they're probably uncomfortable, really focused, or overwhelmed. If they're turning away or trying to get physical distance from you, then that might mean that you are bringing too much towards them. If you might be trying to connect with a patient by making eye contact and mirroring them and speaking emotionally, but if everything in their body is telling you that they are getting too much emotionally from you, you need to dial it back. If they're looking exhausted and flat, then it might mean that they've been masking for a long time and they're running out of steam. So if you see any of those kinds of signals, you need to slow way down. You need to turn down some of the emotional demand that you're making of the person, lessen their load, and find some other ways to make the process and the environment less stressful. Patience. So work against all of those negative assumptions that you might initially have about somebody who seems strange or different. Assume positive intent. Assume that a person is telling you the truth. If they say that they communicate better via email and they don't want to meet with you, don't take that personally. That's something that a lot of providers struggle with because if you go into mental health or clinical care, a lot of times people who do that are very social and they're very empathic. So they want that face-to-face interaction. That face-to-face emotional connection means a lot to them. And so they don't like it when a patient or a student doesn't want to give it to them. But if somebody needs that accommodation, you should give it to them. It doesn't mean they're cold, antisocial, or inauthentic. Trust them to communicate on their own terms and be patient with their own mode of communication. If they ask a ton of questions or don't seem to understand something, check your frustration. It might seem obvious to you because you've done these interviews or you've gone through this procedure a million times before, but it's not obvious to other people, especially if there's disabilities at play. So move really carefully and slowly and give a person as much information and as much time to think and process as you possibly can. For me, and for a lot of autistic people, we don't know what we're feeling until days afterward. We have to really sit and think alone in privacy where we're not going to be judged and harassed to be able to figure out how we really feel. And so sometimes if you are trying to collect valuable clinical information or information about need, you need to pose the questions to the person and then walk away and give them days to reflect and maybe write down their answer and then give it to you. Clarity. Be really, really clear. Say what you mean and mean what you say. Don't use euphemisms. Don't use unwritten, read between the lines kind of efforts at hinting at what you mean, especially if there's some topic that you're uncomfortable with or that's sensitive. That's where people tend to use indirect language. Say if you're talking about sex or body parts that are sensitive or stigmatized, drug use, things like that. Ask directly and explain why you're asking. In medical settings, explain everything that is going to happen in detail and why. You're going to be weighed. Here's why we do it. You can opt out of it. We're going to collect a sample of your blood. Here are the stages of collecting your blood. Here's what tests we're going to run on your blood and why we're doing it. And here's why it matters. And remind the person that they can opt out of things at any time. Asking someone if they can complete a survey. A lot of autistic people, we process very literally, so we hear that question and we'll just say, well, yeah, I can complete a survey. Why are you asking me this? It's not the same thing as saying what you actually mean, which is, please complete this survey and return it to me when you come back to the clinic room or by our next appointment together. Be very, very literal and precise and explain things in multiple different ways as much as possible. Here's some examples of what this can look like. I'm going to ask you some questions about your current mental health symptoms, including things like anxiety, depression, and self-harm. I'm asking these questions because I am required to by law to make sure you are not in immediate danger, and because I have to prove to the government that you are competent enough to agree to start hormone replacement therapy. Unless there is a mental health emergency and we need to get you in touch with immediate help, your honest answers to these questions will not get your HRT taken away. This is an example that you might see with a trans patient seeking care. So you're giving clarity on what's being asked and why, and you're also telling the person that they can trust you with honest information and what will happen if they are honest and what could potentially occur if they say that they are in crisis, so they can make their own decisions about what is safe for them to divulge. Please sit in one of these chairs by the door. In a few minutes, another assistant will come by and lead you to where the blood tests are done. We will need 2 vials of your blood in order to check your body's hormone levels and to check your cholesterol and red blood cell count. We do this because taking testosterone can alter these numbers, and we have to make sure you remain in a healthy range. You might also, in this example, want to go into further detail. If you have too high of a red blood cell count, you're at a risk of strokes, and we might ask you to donate blood. So that's why we're checking your blood. The more detail you can give, the less anxiety you're going to provoke, and the more prepared your client or patient is to move forward. You also want to give as much autonomy to the individual as possible. Patient-directed care is a principle that really says that it is the individual seeking help who knows their own body, they know their own needs, they know their own lifestyle best, and they should be the one driving what kind of care and what kind of interventions they get. You shouldn't impose your goals on a person from the outside. Not every disabled person wants to have a million friends and be liked by everybody. Most of us aren't going to have full-time jobs. Some of us aren't ever going to complete a high school diploma or college degree. Those are society's goals, right, that have been imposed on us from the outside. Instead, listen to the person about what motivates them. And even if they are a person who can't speak or is really intellectually disabled or has really high support needs, even if they can't spell out for you what they're passionate about, watch them. Behavior is communication. What makes them excited? What makes them happy? What makes their life worthwhile? And what can you do to empower them to get as much of that as possible? Give them flexibility as much as possible. Remind them that they are free to say no to things, that they can leave the room, that they can stop a procedure, that they don't need to aspire toward a goal that doesn't suit them. And also, I think it's really important to be grounded in harm reductionist principles. This book by Shira Hassan, Saving Our Own Lives, is an absolutely beautiful book on harm reduction as it applies to a variety of different health behaviors. So don't assume that cutting is always bad. That might sound really wild and controversial, but people cut to regulate their emotions, to express that their body is their own, to do whatever they want to with. They do it sometimes because they want the scars, because they want to communicate that they're in pain. They do it for the endorphin rush. They do it because it turns them on. People make choices about what to do with their bodies for a reason. And if it seems like somebody's doing something that's complete nonsense to you from the outside, that means you don't understand their context. So eating disorders serve a function. Addictions serve a function. Any kind of behavior that we might pathologize from the outside, a person is engaging in it for a reason. And so you should be curious about why they're doing it, what need they're trying to meet, and how you can help them be as healthy as they can be and as comfortable as they can be while still exercising that body autonomy. So whether that's giving them clean needles to use to shoot up their drugs, or deciding that maybe for them and their eating disorder recovery journey, they're only ever going to eat a handful of foods that they like. And you want to make sure that they supplement the nutrients that they're missing. But if they only ever eat chicken nuggets and apple slices, because those are the only foods they can tolerate, that's okay. That's their body, and that's their decision. And also, there should always be, as I kind of mentioned, an escape route from any treatment, appointment, conversation that is overwhelming. They should be able to get out of that environment to self-regulate. In terms of making spaces physically accessible, there's a lot that you can do. I would direct you to the Autistic Self-Advocacy Network's accessibility guide on their website. Their principles for making accessible spaces and accessible events are very wide and encompassing. It's not just for autistics. It's for people with physical disabilities, deaf people, blind people, people with sensory sensitivities who aren't autistic, all kinds of different disabilities and differences. And they really go down the line of remember to not have applause, to not have flash photography at an event, to have a fragrance-free policy because a lot of people get migraines and overwhelm from fragrances. Make sure to have ASL interpretation for any kind of meeting or appointment. Image descriptions for any photos and any materials you hand out, and on and on and on. If you go through their guide and check off the boxes, you will have a more physically accessible, comfortable space. You can also follow the principles of good universal design. So you want to have multiple modes of transmitting information. You shouldn't only give out information from one face-to-face interaction. We know that's the worst way to learn. As a professor, there's lots of pedagogical research that shows a lecture is just about the worst way to teach somebody information. Ironic, right, that I'm doing this right now and saying that. People need to be able to read the information, complete some kind of activity related to it, write down notes, ask questions, and hear information multiple different times if they're going to really internalize it. So any information you give out, make sure you have captions and image descriptions. Make sure you have both a written agenda for a meeting as well as the meeting itself. Keep a recording of the meeting and send that so people can re-listen to it. Have multiple different modes of transmitting information as much as possible. Also have multiple different modes and time points for collecting feedback. So don't just ask a patient if they have questions in the heat of the moment in the clinician's office. Also check in with them a day or two afterward on, a private message or an email and say, have you had any other questions? Has anything else come up? And here's a summary of everything we discussed. This is also true for educational settings or workplaces. You want to give people multiple chances and multiple ways, whether it's an anonymous question box that people can put a piece of paper in, or multiple series of meetings and listening sessions, or both a live interaction and kind of a private written interaction. Give people multiple ways to be heard, because some of us cannot communicate verbally in the heat of the moment. Also, be aware of competing access needs. So this is an idea that what may be accessible to one person may actually disable another person. So we see this in the interactions between ADHDers and autistics a lot. A lot of ADHDers, what they need is social stimulation. They need things to be fast-paced and exciting. They want to be in the room doing the activity, and that's how they learn. That's how they follow things. For a lot of autistic people, that is the most distracting, annoying, overwhelming thing possible. A room with a bunch of other people talking excitedly and completing tasks and moving around is so overwhelming that you can't process a thing. And so you might need to process, if you're that person, in a quiet, private space with written instructions or written information and nobody else around. What works for one person can disable another person. And so there is no single answer. And also, every disabled person is different. There are plenty of autistic people who do want noise and stimulation. There are plenty of ADHDers who get distracted by noise. These are generalities that don't apply to everyone. And so bring humility and curiosity to your every interaction so that you can meet the person where they are at instead of operating based on stereotypes about what they need and what they want. The final message that I'll leave you with today is that this work of unmasking ourselves, of being more authentically ourselves and building more accommodating spaces really benefits everyone. When you communicate more clearly and literally, you're not just helping neurodivergent people, you're also helping people who are deaf or hard of hearing. You're helping people who have anxiety and social anxiety. You're helping people for whom English is not their first language, and so they might not know every idiom or turn of phrase or euphemism. If you have physical spaces that are less bright and noisy and smelly, then you're going to help migraine sufferers and people with allergies, not just people who are autistic or have sensory processing disorder. And if you move away from a culture where we all have to fake a smile and hide all of our other emotions, you are going to make a world that is less exhausting for everyone. It's not just disabled people who mask. Every single customer service representative has to fake emotions that maybe don't feel right for them and are really draining for them some of the time. Every medical provider or therapeutic provider has to fake emotions and has to suppress sides of themselves that are seen as too much or inappropriate for that setting or just different. Neuroconformity really is a societal pressure that weighs down on all of us. And even though I talk a little bit about non-neurodivergent people here or neurotypical people here, really what we're talking about is a spectrum of the ability to neuroconform. Some of us can fit in better in this world and can fake it more, but no person is really suited by a world with such harsh rules, such limiting restrictions on behavior, and where there's so much judgment levied against anyone who does anything a little bit differently. So when you make your spaces more accepting and accommodating, you really are benefiting everyone, including yourself, and you're going to have better quality interactions with your patients, your students, your clients, and so on. Here are some places that you can look for more resources if you're interested. I write regularly about this stuff on my Substack. The Autistic Self-Advocacy Network is amazing. RealSocialSkills.org has tons of cool tools. The book Disability Visibility by Alice Wong is excellent, so is many of the other books that I talked about today. The Protest Psychosis, Psychiatric Hegemony, Saving Our Own Lives. There's so many great texts out there for learning more about this stuff. And if you'd like to learn more about autism in particular, some great starting places are the blog Neuro Wonderful and the video series on YouTube, Ask an Autistic by Amethyst Shaber. So this is just a starting point. But I hope it gives you some things to think about. And most of all, I would just caution you as a provider to just move with greater patience and to question your reactions, especially when you feel like you don't get someone or you don't like them. That alone can make a huge difference. So thank you everyone for listening and for being here and for wanting to do better by your neurodivergent peers, colleagues, clients, and patients. Thank you. And with that, I'll stop my recording.